Thanks, Marla. I'm really excited to be here. Thank you all for being here on what looks like a wonderful Saturday outside, and I hope we have enough science and clinical management here to continue making this afternoon very productive and useful for everybody. And so over the next 20 minutes, I wanted to talk about a topic that is pertinent to virtually everybody taking care of patients with IBD. This is a clinical scenario that we've come across many times, and there are challenges and nuances to managing this difficult patient population. And so let's see what the science tells us in how to manage this particular condition. Okay, so these are the 5 points that I want to cover: the pathogenesis, risk factors of C. diff infection, clinical features and diagnosis, treatment, but also spend a little bit of time on refractory and recurrent disease, which is a really challenging clinical situation, and finally a couple of take-home messages in how to manage this complication. So this is data that we published over 10 years ago, but has been shown by many groups. If you look at what's happened to C. diff, which again, just note the header that the term isn't Clostridium difficile anymore. There's been a change in how you label this bug. It's Clostridioides difficile. But essentially, this is a gram-positive spore-forming anaerobe that was first identified in 1978, so not really that long ago. But it's really exploded all over the healthcare, and in many situations, it's the most common healthcare-associated infection. And so it really is a very important condition to study. This is a trend of new diagnosis of C. difficile in hospitalized patients over 15 years, from 1993 to 2008, and you see how it's really exploded, going from a very uncommon infection in 93 to something that affects up to 20 per 10,000 patient days currently. So 2 per 1,000 hospitalized patient days are complicated by C. difficile infection. Several studies have shown that there really has been a doubling of infection between 1999 and 2003, which is where there was this emergence of the epidemic strain of C. diff, initially in Canada, but subsequently globally. The estimated cost of C. difficile infection is $3.2 billion annually, and it accounts for over 50,000 additional inpatient days. So very important infection that's associated with a lot of morbidity. What has also changed over the past 20 years that I think it's important for us to recognize is that when C. diff first came on in this space 20 years ago, it was primarily thought to be a hospital-acquired infection which affected only hospitalized patients, and we were not really thinking of C. diff as a problem outside the hospitalized setting. But that's not really the case at all. So this was a study from the Mayo Clinic that looked at something called community-acquired C. difficile infection and showed that there was a 41% increase in rate of this community-acquired infection. And importantly, different from healthcare-associated C. diff infection, antibiotic use was much less common, so 78% of community-acquired infection compared to virtually everybody with hospitalized C. diff infection. So it's important to keep in mind that it's not restricted to the hospitalized setting anymore, and any outpatient with IBD, we should be thinking of this, because this is an important community-acquired problem as well. There are many risk factors for C. diff infection, some of them modifiable and some of them not. There are some risk factors that are intrinsic to the patient themselves, so older age, greater comorbidity. Studies have shown that host immunity and ability to mount antibody response to C. diff infection is an important determinant for whether someone is a carrier or is going to suffer from that infection. There are a number of extrinsic risk factors as well that are not specific to patients with IBD but are important in this population as in any population. So antibiotic use, as we saw, is a common risk factor for C. diff infection, but up to a quarter to a third of patients with IBD may not have this risk factor, so it's important to not think of it as exclusively linked with C. diff. Proton pump inhibitor use has also been reported in some studies to be associated with C. diff infection, as has recent hospitalization. So these are general risk factors that are not specific to the IBD population. But in addition, there are some risk factors that are really specific to those with IBD that it's important for all of us to be aware of. So immunosuppression, and particularly use of systemic corticosteroids, has been associated with about a 2 to 3 times increase in risk of C. diff infection. It's less clear whether an anti-TNF and anti-integrin, other immunomodulators increase this risk, but clearly systemic steroid exposures increase risk of C. diff infection. Studies have also shown that colonic disease, so whether you have ulcerative colitis or colonic inflammation from Crohn's disease, that seems to be associated with an increased risk compared to those with small bowel disease alone. And some studies have suggested that having active inflammation in the colon further predisposes to C. diff infection, though it becomes very difficult to tease out cause and effect in that situation. It's very, very important to note that symptoms and signs of C. diff infection in those with IBD are indistinguishable from IBD flare. So there really is not a typical symptom that will tell you that this person having diarrhea has it from C. diff versus from their underlying IBD. It can present as diarrhea with or without overt bleeding, abdominal pain, leukocytosis, low albumin, and anemia. Imaging in patients with C. diff will show either toxic megacolon or free perforation if they're really, really ill, but otherwise tends to be normal. A CT imaging will show wall thickening and increased vascularity in the colon, just suggesting active colitis. Again, it does not separate out active IBD from C. diff, and so does not rule in or rule out the possibility. In a person who's not immunosuppressed and who generally does not have IBD, the typical finding for C. diff is the pseudomembranes that you see here, which is sort of this wall of mucus that you get lining the wall of your colon. And in patients with IBD, which is on the far side, it looks just like active colitis. So there is not an endoscopic finding that's typical of C. diff in patients with IBD. And having or not having pseudomembranes does not influence whether that person has C. diff or not. Typically, when we manage C. diff infection, we try to stratify patients by their severity, and I have here the list of features that define the various severity strata based on their ACG guidelines for managing C. diff infection. So mild to moderate, where they present with just diarrhea. Severe disease, where they have diarrhea but also have a low albumin and perhaps an elevated white blood cell count, and complicated disease where there's further complication by hypotension, need for ICU admission, mental status changes, severely elevated white blood cell count, or end organ failure. So these are broadly the criteria that separate out mild C. diff, severe C. diff, and severe and complicated C. diff infection. And it's important to keep this in mind when we're managing our patients. Many studies have looked at the impact of C. diff on IBD, and there is a tremendous negative impact that happens. So studies have shown that in the context of IBD, if a patient has C. diff, they may have increased mortality, longer hospital stays, greater hospitalization costs, increased need for emergency room visits and therapy up titration up to a year after diagnosis of C. diff, and need for escalation of therapy. So there's the short-term impact on disease, but it can also have a long-term impact on disease up to a year after that index infection, and it's important to keep that in mind. Really, the only way to reliably make C. diff diagnosis is by lab testing. It's important to test primarily diarrheal stool. Don't test formed stools. If they have formed stools and you find C. diff, it's more likely that they're carriers than it's actual infection. Usually a single specimen is sufficient, though some studies have suggested, at least with the older test, that you may need more than one. Most hospitals now use two-stage testing, where they use an initial screening test, which is typically the GDH test here, which has high sensitivity, but it's not specific for C. diff. So having it positive does not make it that this person has an infection. If this initial screening test is negative, then it's highly unlikely that there's underlying C. diff infection. Usually this positive screening test is followed by a confirmatory test, either a toxin ELISA or a PCR test, where they generally, the current versions of the toxin ELISA and the PCR test have fairly high sensitivity and specificity. One concern with using PCR testing is that it doesn't look necessarily for the presence of toxins, but it looks for the presence of toxin-producing C. diff infection, toxin-producing C. diff. So carriage of toxin-producing C. diff does not necessarily mean that your clinical symptoms that are happening at that time are from C. diff infection. And so studies have hypothesized that this PCR positivity in the absence of toxin positivity actually represents colonization with toxigenic C. diff and does not represent actual disease. So this very nice study looked at their large cohort of patients who had C. diff infection and grouped them into 3 separate categories, and it's important to keep this in mind. So about 80%, which is the blue part of this pie chart, were toxin negative, PCR negative, so they didn't have C. diff infection. The red slice in this pie, which was 11% of patients, were toxin negative but PCR positive, and the remaining around 10% of patients were both toxin positive and PCR positive. And so this is where you run into the discrepancy where someone is toxin positive by ELISA or by PCR but negative by ELISA, right? Which is a common clinical situation that I'm sure many of us have come across. So let's see what happened to this group. What they found in general was that people who were toxin negative but PCR positive had generally less fecal C. diff load. They tended to be exposed to antibiotic less. They had less fecal inflammation if you use calprotectin or other fecal inflammatory markers, and had less diarrhea. And this toxin negative PCR positive patients, actually none of them suffered a C. diff related complication compared to the toxin positive PCR positive where about 8% had a C. diff related complication. So just be aware when you're interpreting the C. diff toxin ELISA discrepancy. If they're toxin positive, they clearly have the infection and should be treated. There is a subgroup of patients who are going to be PCR positive or toxin negative, where many studies, that group generally tends not to have poor outcomes. Caveat, this is not in patients with IBD. This is in the general population where there may be sort of other factors playing a role. There's not as much data specifically in the IBD setting what to do with this, what to do in this situation, and we can discuss further in the panel towards the end of the talk. The treatment for C. diff had traditionally been metronidazole 500 milligrams every 8 hours. I'm going to put a big red X over that because we are not using this anymore. Neither the ACG guidelines nor the IDSA guidelines recommend metronidazole for first-line treatment of C. diff infection, so we should not be using this in our patients with IBD. First-line treatment is typically either vancomycin, and I've written the dose there, 125 milligrams every 6 hours for 10 to 14 days. It's important that IV vancomycin has no role, and this comes up sometimes that your patient with IBD is hospitalized, they're on IV vancomycin for something else and are now C. diff positive. That IV vancomycin is doing absolutely nothing for their C. diff. It does not get into the colon. It does not cover their C. diff. You need oral vancomycin for there to be a benefit for C. diff infection. The other option is Fidaxomicin, which is dosed at 200 milligrams twice a day for 10 days. And these should be your first-line treatments for C. diff in patients with IBD. This was a study that's now over 10 years old, which really highlighted the importance of vancomycin, particularly in severe C. diff infection. So this study from Chicago classified patients as mild or severe C. diff based on sort of their illness burden, and showed that for mild disease, well, there was no difference between metronidazole and vancomycin. There was a clear benefit for vancomycin in those with severe disease. Other studies have now shown that even for mild disease, vancomycin is superior to metronidazole, and again, should be a first-line go-to in patients with C. diff and IBD. Fidaxomicin was compared to vancomycin in this randomized controlled trial that was published in the New England Journal in 2011. And you see that for their primary outcomes of clinical cure, which are the bars that are closest to me here, in their modified intention to treat or per protocol analysis, there really are very, very comparable outcomes, so you can pick whichever of the two. However, where there was a difference between the two was in recurrence rate. So Fidaxomicin tended to disrupt the microbiome to a lower degree than vancomycin. Consequently, the rate of recurrence of C. diff infection after an initial course of Fidaxomicin was much less than with vancomycin. So in someone who perhaps has a tendency towards recurrent C. diff infection, you may want to consider Fidaxomicin as sort of the first line, with the aim of not that they will feel better any sooner, but that their overall recurrence rate may be less. What to do about immunosuppression when someone has C. diff? And this is a common challenge that we face. There was a single retrospective study done from Israel and various other groups that were part of ECHO that showed that there was worse outcomes in people who were treated with antibiotics and immunosuppression. But it's very, very, very important to note that this was a retrospective study where patients were not randomly assigned to receiving immunosuppression or not. And it's very, very likely that the patients who continued immunosuppression were those who generally were more ill with their IBD, and so the treating physician did not feel comfortable stopping the immunosuppression. So I do not take away from this study that immunosuppression is necessarily bad. But that being said, steroids, which have been shown in many studies to be bad for a number of different outcomes, you may want to dial back the steroids, primarily if C. diff is driving their inflammation. I would avoid escalating immunosuppression in the setting of active, untreated C. diff infection. So all these phrases are important, at least for me in my clinical practice. However, in hospitalized patients with fulminant disease, concurrent antibiotic use and immunosuppression, including biologics or cyclosporin, may be required in a steroid refractory setting. So I would also take away from this that just because someone has C. diff infection and you're treating him for it, it doesn't mean you're going to have to hold their systemic immunosuppression for their IBD for days or weeks. I would not escalate it as the sole treatment when I have not treated the C. diff infection, but when I am treating the C. diff infection, I feel comfortable escalating their immunosuppression if they need it. For refractory C. diff, it's really important, particularly in hospitalized patients, to obtain early surgical consultation. Studies have shown that a delay in colectomy beyond 6 days was associated with worse outcomes. In really, really ill patients, you can combine oral vancomycin with either vancomycin retention enemas, which help get some colonic vancomycin concentration when someone has ileus otherwise. You can use intravenous metronidazole, which does get into the colon and is helpful in this setting. There are other therapies that I've listed there that have been tried, including FMT. Again, very little data, but can be considered in the ill patient. But again, keep in mind that delay in surgery results in worse outcomes. So you don't want to delay that indefinitely trying all these different treatments. Where we face challenges with particularly is recurrent disease. About 20% of patients after their first episode can get recurrent C. diff. Once they've had recurrence, they're more likely to get recurrence. So once they sort of go into this circle, they keep getting recurrent C. diff. 65% of patients who've had 2 or more recurrences can get recurrent C. diff as well. There are a number of risk factors for recurrence, but primarily it's continued antibiotic use and continued disruption of your gut flora. There are many other risk factors that have also been listed for recurrent disease. I've listed there: duration and type of hospitalization, prior recurrence, and previous MRSA infection, older age, comorbidity. For management of recurrent disease, it's important to eliminate sources of reinfection, retreat with the same drug, possibly, but again, if your first line was vancomycin and this person has recurred, you may want to consider Fidaxomicin given its lower recurrence rate. Studies have looked at prolonged courses of vancomycin for 4 to 6 weeks. Fecal transplantation, which I have on the next couple of slides, is really something we should be thinking of up front in people who've had multiple recurrences of C. diff infection, and there are a number of other treatments as well that I've listed there. If you look at this monoclonal antibody, again, toxin. So this was the MODIFY study that was published in 2017, looking at a single infusion of an antibody against toxin A and toxin B, and showed that there was a significantly lower rate of recurrence in those who were treated with this combination toxin compared to placebo. So it's an option that is available. Fecal microbiota transplantation is really the most effective treatment for recurrent C. diff infection. So this was the Van Noot study that was published in 2013 in the New England Journal that looked at duodenal infusion of donor feces and showed that with a single fecal transplantation that way, 80% had no more recurrences. And if you allow for a second treatment in those who failed the first treatment, over 93% did not have any recurrence. And you see here how much it outpaces use of vancomycin for prevention of recurrence. So it's important to think of this as an option and not really wait till too late in the game. The long-term efficacy of fecal transplantation has been looked at in several studies. This was a series of 77 patients who underwent colonoscopic FMT and showed that 82% had resolution of diarrhea within a median of 1 day. A primary cure rate, which is with a single infusion, 91%. A secondary cure rate, which means allowing for a second infusion, 98%. Specifically within IBD, people have looked at the efficacy of C. diff infection and this theoretical risk of does it result in a flare-up of IBD. In 9 cohort studies that included 350 patients with C. diff, very good cure rates of FMT for recurrent C. diff and IBD, so almost 90% with a recurrence rate of 19%. And there really was no difference in performance of FMT between those with and without IBD in this analysis. A group also looked at the risk of an IBD flare happening with fecal transplantation, looking at over 500 FMT-treated IBD patients, and showed that there was a flare rate of only about 15%, which is not that different from when you use FMT for treating IBD itself, so 11%. And if you look at high-quality studies alone, that risk is about 5%. So generally, that risk seems to be low, and a previous sort of understanding of how common this is, it's probably not as common as we think. And finally, the very last slide I have is what about when someone has had C. diff? Can you secondarily prevent C. diff? Studies have looked at probiotics for prevention of C. diff in someone who's had C. diff before, and probiotics are effective and reduce the rate of developing new C. diff infection by 60%. There are 3 studies that also suggested that co-treatment with oral vancomycin when someone who's had C. diff before goes on other antibiotics reduces risk of C. diff in high-risk patients. So this is something that I do sometimes in my population where they've had C. diff before and now need to go on systemic antibiotics. There are 3 studies that suggest that there's some benefit to co-treating them with oral vancomycin. C. diff can happen in the small intestine as well, so don't forget C. diff can complicate pouchitis, can lead to enteritis in someone with an ileostomy, can happen in the diverted bowel as well. So really take-home messages: C. diff is common and impactful in patients with IBD, have a high index of suspicion since you cannot clinically distinguish it, and antibiotic exposure is not mandatory. Oral vancomycin or Fidaxomicin are first-line treatments. Avoid escalating immunosuppression, but co-treatment is frequently needed. And recurrence is common, and I've listed all the options for recurrence there. So thank you all for your attention.